In Asia, myopia control isn't just an issue, it's actually a major public health priority, from atropine and optical interventions to increasing outdoor time. All of this is happening in the context of unique challenges in Asia, like very reduced outdoor space and very high educational demands. Hi, I'm Seo Wei Leo, and in this session, we'll explore how to apply the WSPOS 2025 consensus to real-world Asian clinics, where the challenges are big, but the solutions can be even bigger. For myopia control treatment in children, it has to be patient-specific and customized to the child. So I will stratify risk factors and environmental factors of the child. We look at the child's age of presentation, the cyclorefraction, that means the amount of myopia, the axial length of the child, and the health of the eye. Is there any other issues, like is there allergic conjunctivitis? What is the cornea like of the child? Any family history of myopia, family history of pathological myopia, like retinal detachment. Also, what is the lifestyle like? What is the near work time? What is the outdoor time of this child? What is the lifestyle like? Is the child always on digital device? Because as a whole, we have to come up with something that will suit the child. And ultimately, the easiest way to start off is to change the lifestyle, cut down on gadgets, cut down on unnecessary near work, and go outdoors a lot more. So in Asia, we've been using atropine for myopia control for a long time. So monotherapy, I will use that when myopia is milder, it's an older child, the progression is not that much. For combination therapy, it is increasingly popular because by combining two treatments of different mechanisms of action, you can actually enhance the effects and avoid side effects of like a high-dose atropine, for example. So combination therapy can be used if the child is not responding to just monotherapy, or the parents are very motivated and they want a very strong sort of treatment. If the child is very young, the myopia is very high and progressing very rapidly, especially if there's a family history of pathological myopia like retinal detachment and all that, then we tend to go full on with combination therapy if the parents desire. Public awareness is high, but it can be uneven. So as you know, in Asia, we have a lot of different options, different types of contact lenses, different myopia control glasses, the pharmacological treatment like atropine in the different dosages. All these are important to be educated and to come across to the parents very clearly. Lifestyle advice is very important. We always ask them to take vision breaks, cut down on excessive near work, and most importantly, to go outdoors a lot more. I always emphasize the need of outdoor. You need to be outside and have at least 1,000 lux, if possible 10,000 lux, so 2 hours of that. School-based or government-based policies will help to reinforce the importance of cutting down on the intensity of the near work and to increase outdoor time, to let them look far and increase outdoor time as much as possible. In Singapore, we've had quite a lot of success with a lot of good campaigns by our health promotion board to keep myopia at bay. So they tell them to go outdoor to play that. That's the slogan, and it's been quite well received. And of course, in countries like Taiwan and China, they have had very good success with their public health policies as well to reduce myopia progression and myopia prevalence and onset too. Cost is always an issue when discussing treatment options with parents. At the end of the day, it's not just about cost, it's also the compliance. So the effectivity depends on the compliance as well. Atropine eye drops, depending on the different formulations, the cost is not as prohibitive as some other optical measures. Some of the optical measures can be a lot more costly, like orthokeratology. And then the myopia control glasses will be kind of like in between myopic defocus glasses. So in Singapore, most parents are cost conscious, but they do understand the need for good myopia control intervention. So as long as we have a clear understanding and after a detailed discussion, most the parents will know the value of myopia control. Once I start the treatment, I will see especially like atropine treatment, I will see the child within a month. We'll look at the accommodation of the child, the pupil size, and how the child is doing in terms of visual acuity, both for far and near, and the compliance, of course. Subsequently, we do at least depending on the severity of 6 monthly sort of check where we look at cyclorefraction and axial length measurements as well. During the consultation as well, I like to compare the treatment results to the percentile chart. So I always monitor the child with the axial length percentile chart. If your treatment is successful, of course, besides looking at the cyclorefraction axial length, your axial length percentiles should get less and less. You should not be on a higher percentile. That's when you know that you are getting successful treatment because you're moving down in terms of percentile charts. For any practitioner, it is very important to keep updated because there's so much happening in this myopia sphere. So we need to be updated. That's why the consensus statement is useful. And once you see a myopic child, do not hesitate. Examine properly, do a detailed examination, treat, and have realistic expectations together with the parents on the treatment options and treatment results. Practice evidence-based treatment.